Now, I start all of my lectures that I ever give anywhere to big audiences at scientific pain meetings or to these lectures here by showing this slide because I think it's a very important point. You can't see pain on an X-ray or an MRI, and there's no chronic pain condition where anything we see on an X-ray or an MRI tells us that person's always going to be experiencing pain, or that person's not going to be experiencing pain, or look at the X-ray and say this person's going to have severe pain versus this person having no pain. There is no chronic pain condition where what we see on an MRI or an X-ray accurately predicts who's going to be experiencing pain or how severe the pain is going to be. Now, the disease I'm going to talk about today to use as a metaphor along these lines is the disease called osteoarthritis. Osteoarthritis is by far the most common cause of chronic pain because it is the type of arthritis that almost all of us will get if we live to be old enough. Almost all of us will develop osteoarthritis in weight-bearing joints like the knees or the hips if we live to be old enough. And because of that, osteoarthritis is sort of the 800-pound gorilla in the pain field, is that if you look at the entire population, including the elderly population, that osteoarthritis is usually the most common cause of chronic pain. But the way osteoarthritis was conceptualized 30 or 40 years ago when I was first trained as a rheumatologist is that the more destruction of the joint that someone had, this is a knee joint. This is an entirely normal knee joint. That big black stripe means the person still has cartilage at the end of their femur or at the top of their tibia, because cartilage doesn't show up on an X-ray, whereas bone shows up as white. So when we see that big black stripe, as a rheumatologist, we like that because we know that there's still a lot of cartilage there. And again, theoretically, that knee is not supposed to hurt. That's an entirely normal knee X-ray. This knee is supposed to always hurt. Person has totally lost their cartilage, they have bone rubbing against bone, and this is always then going to lead to pain. Problem is, that's totally false. 40% of people in the United States that have an X-ray that looks like this have no pain whatsoever. They have lost all their cartilage, they have bone rubbing upon bone, but they're not experiencing any pain or any symptoms whatsoever. And 10 or 15% of people with severe knee pain will have an X-ray that looks like this, that there's nothing wrong with them. And by the way, one of the reasons that the title of my talk, Chronic Pain, Is It All in Their Head, is that many of you, unfortunately, have been told over the course of your lifetime, you've come in with pain, someone has done an X-ray, and they saw an X-ray more like this than an X-ray like this, and they said something like, there's nothing wrong with you, it's all in your head. But they've sort of implied that you're making up the pain because they can't see it on an X-ray. Again, I'm one of the leading pain researchers in the world. Let me tell you, there's no chronic pain condition where what you see on an X-ray or what you see on an MRI can tell you whether the person's experiencing pain or not. There is always a tremendous disparity between what we see on an X-ray or an MRI and whether people are experiencing pain. And the disparity goes in both directions. It goes in the direction is that you would expect this person to have pain and they don't, and you would expect that person to not have pain and they do. So why is that? Why? So one of the analogies that I began using about 6 or 7 years ago, by the way, I try out most of my new material in my talks on you guys, in my patient talks before I go out and give my doctor talks and my science talks. But I use all the same slides to talk to patients as I do to use in my scientific talks. And this is an analogy that I came up with about 6 or 7 years ago that seems to be helpful in allowing people to understand what I'm talking about when I'm talking about the role the brain has in sort of controlling the volume control or the setting of pain. And the analogy that I'm going to use now is that the amount of pain that a person is experiencing is akin or analogous to the loudness of an electric guitar. And so there's two ways you can get an electric guitar to be louder. You can either strum the strings harder, and then thus it'll be louder, or you can turn up the amplifier. And if you turn up the amplifier, it's not just a single string that will be louder. All the strings that you strum will be louder if you turn up the amplifier on an electric guitar. So what's the analogy to human pain? Well, the brain and the spinal cord, which we call the central nervous system, are analogous to the amplifier setting on an electric guitar. whether you're going to feel something that's going on in your knee is partly what's going on in your knee, but it's partly what is your amplifier setting in you as a person. If you happen to be born with a high amplifier setting such that you are more pain sensitive, you feel pain with the amount of pressure or the amount of heat or cold that someone else wouldn't necessarily experience as pain, and that the fundamental problem in you is that your amplifier is turned up, then you'll feel more pain anywhere in your body, because these strings on the guitar are analogous to the nerves that you have going to your muscles and your joints and your bones and things like that. If the amplifier is set too high, strumming any of these strings will lead the guitar to be louder than it would be if the amplifier was set at a normal level or set at a low level. And in fact, this really helps explain a lot of this variance between what we see on an x-ray and whether the person's experiencing pain or not. So I'm superimposing the knee on the guitar, because that's the analogy that I'm using here, is that the nerves that are going to the muscles and the bones and the joints in the knee are bringing information from the knee to the spinal cord and the brain. But whether you feel what's going on in your knee as pain or not is just as much due to what your amplifier is set at as what's going on in your knee. And that helps explain why a lot of people that have a lot of stuff going on in their knee, 40% of people that have a knee x-ray like this, don't hurt, because these people have a low amplifier setting. These people are inherently pain insensitive, and thus, even though they have a really gnarly looking knee x-ray and there really is something wrong with their knee, they don't feel any pain. But the people at the other end of the continuum are people that have conditions like fibromyalgia, irritable bowel, vulvodynia, temporomandibular joint disorder, all of these conditions now that are thought to be much more so a fundamental problem with the volume control in the brain. And even though you're, at the time that you get those diagnoses like irritable bowel or vulvodynia or interstitial cystitis, you have pain in the abdomen or the bladder or whatever, that's not where the fundamental problem is in those conditions. The fundamental problem when people have those conditions is really now thought to be much more so a volume control setting. And in fact, the National Institutes of Health in the United States a couple of years ago basically came up with this new label called chronic overlapping pain conditions. And what they said is conditions like fibromyalgia, irritable bowel, interstitial cystitis, endometriosis, they have 8 conditions that fall under this label of chronic overlapping pain conditions. That what we've learned is that those are all really the same fundamental problem in the brain, but the people get labeled with the label that implies that the problem is in the area of the body where the person's experiencing pain. So they get labeled with irritable bowel syndrome. They get labeled with interstitial cystitis because it's in the bladder. They get labeled with TMJ syndrome because the pain is in the jaw. But that isn't where the problem is. That in those conditions, the reason the NIH came up with this new umbrella term for all of these conditions is the problem in all of those conditions is now really thought to be one fundamental problem in the volume control setting in the brain. And so it's very common for people over the course of their lifetime to be given 2, 3, 4, or 5 of those labels, because it's just the first area of the body that your pain showed up in is the first label that you'll get. If it turned out that when you were 15 years old, the first chronic pain condition that you experienced was painful menstrual periods, then the label you would get would be primary dysmenorrhea, as if the problem was in your uterus. But then 2 or 3 years later, you had pain in a different area of your body. A couple years later, you had pain in a different area of your body. And what we now have come to see is that people with these chronic overlapping pain conditions have one fundamental problem, which is in the brain, that happens to be manifest in different areas of the body over the course of their lifetime. And it's really important to put that together, because once you realize that this is one problem in the brain, rather than the person has 5 different problems in different areas of their body that they have to go to different subspecialists that are in charge of that area of the body to control these symptoms, once the person realizes that there's one fundamental problem that needs to be dealt with, you can deal with it better. And you have a better sort of understanding of where the fundamental problem is and where this problem needs to be attacked. rather than thinking these are different pain conditions that need fundamentally different treatments because the pain is in different locations in your body.